Welcome to the deep dive. Today, we're jumping into, well, a really challenging but also incredibly rewarding area. Lower extremity reconstruction.
Mm.
This is about so much more than just, closing a wound. It's function, it's the patient's future. And the field has just exploded in the last couple of decades. It's really changed how we approach things.
It really has. And for our listeners, the residents and attendings, think of this as your focused guide. We're aiming to give you those clinical pearls, those aha moments you can take right into practice, things that help with surgical decisions, managing patients, maybe even smooth out board prep a bit. We want to look at patient evaluation, picking techniques, handling complications, all geared towards getting the best functional results.
Exactly. Our mission here is to pull out the absolute must-know nuggets from the source material on lower extremity reconstruction. We want you to come away feeling, well, up to speed, confident, maybe even learn a surprising fact or two.
Yeah.
And we're focusing specifically on wounds at the knee and further down. All right, so thinking about those basics, let's talk about the big shifts. You mentioned how much has changed. 25 years ago, the thinking was different. Now, the evidence is pretty strong that limb salvage can actually give outcomes that are, equivalent to primary amputation in many cases. That's huge.
That's a massive shift.
And things like new fasciocutaneous flaps, VAC therapy,
Yeah.
have been real game changers.
Absolutely. But it's interesting, isn't it? Despite all the fancy new tools, the fundamental principle holds firm. Start simple. Always aim for the simplest technique that's likely to work, and crucially, with the least donor site morbidity. We still think in terms of that reconstructive ladder.
Ah, yes, the like.
Secondary intention, maybe VAC, skin graft, then your local flaps, fasciocutaneous or muscle, and finally, free tissue transfer at the top for the really complex stuff. It's still our core decision framework.
Okay, but before we even climb that ladder, let's talk pre-op. What's the one thing that can absolutely sink a reconstruction before you even start if you don't get it right?
The initial assessment, without a doubt.
Right. It seems obvious, but why is it so critical? We're talking about things like diabetes, vascular issues, obesity, smoking.
Exactly. These aren't just footnotes in the chart. They actively diminish the chances of healing. For residents listening, this is where taking a thorough history and just looking carefully pays huge dividends.
So, history first, then the physical exam.
And it needs to be meticulous. You're checking neurostatus, vascular supply, feeling for pulses, looking for signs of injury, limb insensibility. But here's a real clinical pearl. You must examine the wound carefully under anesthesia. That's when you see the true dimensions, the depth, and crucially, any exposed vital structures. Nerves, vessels, joints.
Things that need protecting.
Absolutely. They have to be covered. That exam under anesthesia dictates your entire plan. It turns guesswork into certainty.
And these wounds often come with friends, right? Fractures.
Very often. And the sources are clear. Fracture reduction and stabilization need to happen either before or alongside the soft tissue closure. You have to plan around the orthopedic hardware. Those plates and screws need good soft tissue coverage.
Makes sense.
Yeah.
What about vascular injury? How big a spanner does that throw in the works?
Oh, it's a major factor. It can threaten the limb itself, obviously. It can rule out using local flaps right away. And it definitely complicates microvascular reconstruction if you're going down that road.
So when do you pull the trigger on angiography? For board prep, this is key.
Good question. The indications are pretty clear. Loss of peripheral pulses after injury, any related neurological deficit, or a compound fracture that's been reduced and fixed. Plain film angiography is standard, but CT or MR angiography work just as well.
Okay, so let's summarize. Before you proceed to definitive closure, you need what? A precise wound assessment.
Check.
Vascular injury treated.
Check.
All dead tissue gone.
Meticulously debrided, yes.
Infection controlled.
Crucial.
And fractures stabilized.
Right. The take-home message is, you only move to definitive surgery when the patient and the wound are optimally prepared. It's about setting up for success, not rushing.
Okay, we've set the stage. Now for maybe the toughest call on this whole field. Limb salvage versus primary amputation. This goes way beyond just healing the skin, doesn't it? The real goal is satisfactory function.
It is, and it's where the data gets really interesting, especially regarding those scoring systems like from the LAP study. They were designed to help make this call, but here's the key insight, and this is vital clinical judgment. Low scores can point towards a salvageable limb, yes, but high scores do not reliably rule out salvage. You absolutely cannot rely only on these scores.
So they're a guide, not a definitive answer.
Exactly. They don't replace your clinical assessment and, frankly, your gut feeling sometimes.
That's really important for residents to hear, I think. We often want algorithms. So if the scores aren't the final word, what practical guidance do we have? Lange's work seems helpful here.
It is. For board prep, know the absolute indications for primary amputation. Complete posterior tibial nerve disruption in an adult.
Okay,
And crush injuries with warm ischemia over 6 hours.
got it. Absolutes. What about relative indications?
Things like major polytrauma happening at the same time, severe trauma to the foot on the same side, or if you anticipate a really, really long, protracted course to get everything reconstructed.
That makes sense. It's about the whole picture.
And Boss and colleagues made another critical point, one that might surprise you. An insensate foot just by itself is not a reason to amputate.
Really?
Yes, studies show that patients who have successful reconstruction can end up with functional outcomes just as good as those who had a primary amputation. And getting patients walking early after reconstruction seems really important for getting them back to work too, maybe improving return to work rates significantly. Early ambulation is key.
So function can be equivalent, and Tomato offers a kind of time-based guideline.
Yeah, a practical one. Offer reconstruction if there's a realistic chance the patient will be walking within a year. But again, the prerequisites apply. Patient stable, good local blood flow, wound clean, no contamination, no dead tissue, no infection. Preparation, preparation, preparation.
All right, assessment done. The decision is salvage. How do we actually rebuild? Let's get into the toolbox, starting with local flaps. Dividing the leg into thirds seems like a practical way to think about this.
It really helps organize your thinking. Let's start at the top. The proximal third, near the knee and upper tibia. Your main workhorse here is the gastrocnemius muscle flap, medial head, lateral head, each fed by a sural artery. Its job is plantar flexion.
Okay.
Now, a key clinical point. You can often take one head, sometimes even both, without losing foot dorsiflexion if the soleus muscle is working properly.
Ah, good tip.
But, and this is a big news, but when you're racing that lateral head, watch out for the peroneal nerve. It's right there, very vulnerable. Meticulous dissection is non-negotiable.
I bet. Nerve injury is a disaster.
Absolutely. You can get extra flap length by releasing the origin or scoring the outer layer, the epimysium. It's a robust flap for bigger wounds up there. Proximal tibia, knee, patella.
Okay, gastrocs for the big stuff. What else is in the neighborhood? Tibialis anterior.
Right, fed by the anterior tibial artery perforators. But here's the catch, and it's a major teaching point. It's the main dorsiflexor of the foot. It is not considered expendable.
So you can't just take the whole thing?
Generally, no. But Halleck described a neat trick. You can actually split the muscle longitudinally. This lets you cover smaller defects in the proximal, maybe upper middle third, say, the top 6 to 8 centimeters of the anterior tibia, while still preserving most of that crucial dorsiflexion function. Clever technique.
Moving down to the middle third then. What's the go-to flap here?
The soleus muscle flap. It sits underneath the gastrocs, different shape, bipeniform, gets blood from popliteal, posterior tibial, peroneal arteries, also a plantar flexor.
Any pitfalls with the soleus?
Yes, a big one. You have to be extremely careful not to injure the posterior tibial artery, which runs right underneath it during the dissection. For smaller defects in the right spot, you can also do a hemisoleus flap, split it down the middle. Similar idea to the tibialis anterior split, minimizes the donor site hit.
And I suppose the tibialis anterior split could reach some middle third defects too.
It can for smaller ones, but again, its size and the need to keep dorsal flexion working kind of limit how often you choose it over the soleus if the soleus is available.
Okay, now for the distal third. Historically the tricky zone, right?
But yeah, the Wild West, as some call it. Local muscle flaps just aren't very reliable down there. Traditionally, this meant jumping straight to free flaps. But here's where things have really changed dramatically. The development of local fasciocutaneous flaps. These have been a huge breakthrough for distal third wounds.
And the star player among those is often the reversed sural flap.
The distally based or reverse sural fasciocutaneous flap, yes. It's incredibly versatile and a must-know for residents. Its blood supply comes via arteries running with the sural nerve, connecting with peroneal artery perforators near the ankle.
Okay, anatomy noted. Any practical tips for raising it successfully? Sounds delicate.
Hollier and colleagues laid out 3 critical rules. These are make or break. 1, mark the path of the medial sural cutaneous nerve, that's where the blood supply runs. 2, take a cuff of muscle when you're raising it to protect those tiny vessels traveling with the nerve. And 3, know your limit. The absolute safest distal point to raise this flap is 5 centimeter proximal to the tip of the lateral malleolus. Don't go lower.
5 centimeters proximal, got it.
And because it relies on those peroneal perforators, if you suspect any damage to the peroneal artery, maybe from the initial trauma, you absolutely need a preoperative vascular study to confirm its patent.
Makes sense. Is it better than Other local options down there?
Well, Tuom's group found it had better success rates compared to things like the lateral supramalleolar flap. So yeah, it's often a preferred choice.
So we have these great local options now, even for the distal third. But sometimes they're just not enough, right? Massive trauma, huge defect, maybe the local tissues are too damaged.
Exactly. Or even for proximal or middle third wounds if they're just too extensive. That's when you move up the ladder to microvascular free tissue transfer.
The advanced stuff.
Mm.
What are the go-to free flaps if you just need soft tissue?
The most common muscle flaps are probably the latissimus dorsi. It's huge, broad, flat, long pedicle, great for really big defects. The rectus abdominis also gives a lot of tissue and has a long pedicle. But, and this is important, clinically, it comes with potentially significant donor site problems like abdominal wall weakness or hernia.
Right. Need to warn patients about that.
Definitely. And then there's the gracilis. It's much smaller, better for smaller defects, but the big advantage is minimal donor site morbidity. It's often a favorite for that reason.
Are there key principles for using free flaps, specifically in the lower extremity? Serafin and Voci had some guidelines.
Yes, really important ones for anyone doing these cases. First, do your anastomosis outside the zone of injury. Don't connect vessels and traumatize tissue.
Okay. Makes sense.
Second, aim for end-to-side arterial anastomosis. Venous can be end-to-side or end-to-end. And third, this is critical for function. Reconstruct the soft tissues first. Get the coverage sorted before you start putting in bone grafts or other skeletal support.
Soft tissue first. Got it. How do you pick the recipient vessels?
Park and colleagues emphasize that it really depends on the injury location and the overall vascular health of the limb. Those factors guide your choice for the best chance of success.
And what if you need bone, too? Not just soft tissue.
Then you're looking at vascularized bone transfer. Things like a free fibula flap, often taken with a skin paddle, can address both the bone defect and the soft tissue coverage needs simultaneously. Lee and Park discuss those options.
Okay, let's shift focus down to the foot itself. Even more specialized challenges there. And the big dividing line seems to be weight-bearing versus non-weight-bearing surfaces.
It changes everything. For the instep totally non-weight-bearing, a thick, split-thickness skin graft usually does the job really well, gives durable coverage. Heel wounds, though, much tougher. Smaller defects, especially on the weight-bearing part, might be covered with local fasciocutaneous flaps, like a medial or lateral plantar flap, using their built-in blood supply.
And the non-weight-bearing heel.
That's where the reverse sural flap can be really useful again, covering the back non-weight-bearing portion.
What about the forefoot? Plantar surface there is critical.
For smaller defects on the plantar forefoot, toe fillet flaps described way back by Snyder and Edgerton are excellent. They provide tough sensate tissue, which is ideal for that area. Up on the dorsum of the foot or over the malleoli, if the bed is good, skin grafting can work. For small lateral malleolus wounds, a pedicled extensor digitorum brevis muscle flap is an option.
You sometimes hear about the dorsalis pedis flap for larger malleolar wounds.
You do, but proceed with caution. It relies on the dorsalis pedis artery and the first dorsal metatarsal artery. That first dorsal metatarsal artery can be variable. Yeah, meaning the distal part of the flap might die if you base it proximally. That's a disaster. And frankly, the donor site morbidity can be really significant. If you damage the peritoneum over the tendons or the skin graft you put on the donor site fails, you can end up with exposed tendons. Not good.
So maybe not a first choice then.
Often not. Free tissue transfer is still a very reliable option for big foot wounds, like covering the entire plantar heel. Usually a muscle flap covered with a durable skin graft works well for weight bearing.
Okay, and weaving through all of this is VP therapy. Vacuum-assisted closure. It seems to be everywhere now. Almost like it's created a new rung on the ladder.
It's certainly become incredibly popular, and for good reason. It definitely helps manage dressings and exudate, and it encourages granulation tissue. Some studies suggest it might even reduce the need for free flaps sometimes, but you need the right conditions. The wound has to be clean, the bone's stable, and no vital structures exposed.
The cautions.
Big cautions. VAC is not a magic bullet. It doesn't always work. It's definitely not for heavily contaminated wounds full of dead tissue. And crucially, it absolutely does not replace proper surgical debridement.
Debridement first.
Always.
Always. And you have to be vigilant. There are rare but reported severe complications like arterial erosion and massive bleeding film. White reported a case. It's a reminder to respect its limitations.
So even with the best plan, things can go wrong. Complications happen. We aim for the best outcome, but how do we counsel patients about, well, less than ideal results.
That's a tough conversation. The sources suggest being realistic up front. If the likely functional outcome after salvage looks poor, explaining that honestly can actually help the patient come to terms with the difficult decision of amputation, if it comes to that.
Okay, let's talk managing common complications, hematomas.
Prevention is key. Meticulous hemostasis during surgery is far better than relying on drains. But if you get a significant one, you might need to explore the wound, especially if it's compromising blood flow, causing a lot of pain, looks infected, or just keeps bleeding. What about flap vascular compromise? That sounds like an emergency.
It is urgent attention needed. For a local flap, maybe you can save it by re-exploring, draining a hematoma, or just repositioning it to relieve tension. But for a free flap, it means an immediate trip back to the OR for exploration and fixing the vascular problem. Time is absolutely critical to save that flap.
Infection must be a constant worry, too.
Always. Simple cellulitis might respond to antibiotics based on cultures. An abscess needs draining, plus antibiotics. Retained orthopedic hardware makes things much tougher, bacterially speaking. Ortho often wants to wait for bony union before removing metal, which can be a challenge if infection sets in.
And chronic osteomyelitis, bone infection.
That requires aggressive treatment. Open the wound, remove all dead bone and any involved metal, get good vitalized tissue coverage, often a flap, and then long-term antibiotics. It's a long road.
Definitely complex. And just practically, for the residents and attendings listening, you mentioned CPT codes. That's important for documentation and billing.
Yes, the source material actually lists common ones. Things like codes for adjacent tissue transfers, skin grafts, the various muscle and fasciocutaneous flaps, and all the different types of free flaps, muscle, skin, fascia, bone, osteocutaneous. Knowing these is essential for day-to-day practice.
This has been quite the journey, hasn't it? From that first crucial assessment through the salvage versus amputation decision, the details of local flaps, the complexity of free tissue transfer, foot specifics, VAC, and managing complications. It really highlights how lower extremity reconstruction is this amazing mix of art, science, and just solid clinical judgment.
It really is. And what strikes me is how it's still evolving. We have better techniques, but patients might also have more comorbidities. We strive for limb salvage, but we also have to think deeply about quality of life. So maybe a final thought for you, the listener, to ponder for your own practice. As techniques keep advancing, how do we best strike that balance? The balance between pushing the boundaries of limb salvage and truly ensuring the patient has a meaningful, functional quality of life afterward, especially in these really tough trauma cases. Where does that line sit for you? Something to keep thinking about.